Thanks again to the organizing committee for inviting me to speak at this conference. And I apologize I could not be there in person. And I hope, I know Skype is not necessarily the best alternative, but I hope I can be clear in terms of giving the presentation. Basically, like you said, my name is Tandon, and I'm a senior economist with the Global Practice for Health, Nutrition and Population at the World Bank. I'm based in Washington, D.C., and I work primarily on East Asia and Pacific, and I've been working on Indonesia. I also work on Laos and on Vietnam and some other countries in the region. And I'm going to give a brief presentation on global healthcare financing trends and what some lessons might be for Asian countries, specifically in the context of universal health coverage. Overview of the global health financing landscape. So the graph that you see here is basically total health expenditure per capita from WHO data from 2012. That's the latest year for which we have data available. And it shows that there's this really massive range in health spending globally. At the lower end, some of the lowest spenders in the world are countries like Eritrea and the Democratic Republic of Congo that only spend about $15 per capita per year on health. And then at the higher end, you have countries that spend over 600 times more. So you have countries such as Norway and Switzerland and the US that spend close to $9,000 per capita per year on healthcare. So there's this huge variation, and Indonesia is somewhere at the lower end of the distribution. About the latest estimates suggest that Indonesia spends about $108 per capita per year, very similar to what the Philippines spends and what Vietnam spends. Lower than Thailand and Malaysia, higher than Laos and Cambodia, and Myanmar. Myanmar is one of the lowest spenders in our region of East Asia and Pacific. Now, in addition to this huge, distribution of health spending, countries also differ widely in how much health spending is as a share of the economy, as a share of GDP. And there the range is from about 2% on the low end, which is Myanmar, which is one of the lowest health spending countries as a share of GDP, to a high of the country that I'm sitting in now, which is about 18% of GDP in the US. And Indonesia is really at the lower end of that scale. It's about 3% of GDP. But again, a huge variation in what is health spending as a share of GDP globally. Due to these very strong variations, very large variations in the levels of health spending and the shares of health spending as a share of GDP, you also have very significant variations globally on how health expenditures are financed. You have less than 20% of total health spending that is public, of public sources in Sierra Leone and Georgia. The remaining is all out-of-pocket spending. So about 80% of health spending in Sierra Leone and Georgia is out-of-pocket. And then you have at the other end countries such as Cuba and Timor-Leste, where more than 90% of health expenditure is publicly financed. Indonesia is somewhere in the middle. About 40% of total health expenditure is public in Indonesia. Next slide, please. So another interesting stylized fact is that health is a growing share of the economy. And if you look at this graph, it's basically showing in globally versus East Asia and also for Indonesia, what is the share of total health spending of GDP from 1995 to about 2012. And you can see that health share of GDP globally has grown from just under 6% of GDP to now almost 7% of GDP. So that's an increase of about 1 percentage point in the past, about 15 years or so. And the share across EAP countries has also risen in similar magnitudes. And there's a variety of reasons why this occurs. It's because of changes in income. As countries become richer, they tend to spend more on health. demography, you have aging, you have epidemiological changes, move towards NCDs that tend to require much more expenditure, and changes in technology and access to new medical equipment, as well as procedures that are contributory factors to health share of the economy growing. And we often in the health sector tend to view this negatively, but it's not just negative, it's also that you're getting more from what you're spending, and also health industry is becoming a prominent source of employment and a source of revenues for itself, including from medical tourism. Many countries in Asia are doing very well on that front. For remittances, Philippines is a key example. Exports a lot of health-related labor. Pharmaceutical and medical equipment trade. So in addition to just viewing this as an expenditure, taking a larger chunk of GDP, it's also a contributor to the economy. And I think that's something that we in the health sector tend to sort of undersell. Next slide, please. So let's go back to this question that I raised in my first slide. So, we talked about, levels of total health spending and shares of GDP, but really, how is health expenditure financed? And there are big differences globally as to how health expenditure is financed. And traditionally, there are 5 different models that have been highlighted by experts and those in the literature as to how health spending is financed globally. The first model is what is called the beverage model, or the tax finance model. Here, basically, health expenditure is financed mostly out of general government revenue. So basically, a share of the government budget is set aside for health, and that health care is then provided, usually through publicly owned facilities, to everybody in the population. And a famous tax finance beverage model is the UK. It's often also called the NHS model, following the term that is for the UK's health service provider, the National Health System. And a second sort of slightly variant of this is the social health insurance model, also called the Bismarck model. And one big difference here is that whereas the tax finance beverage model, your healthcare service delivery is financed out of the general government budget, under social health insurance, you have to pay a dedicated tax, usually out of your income, and also a tax on employers, that then goes to a separate pool, and that pool of resources is then used to purchase health services. So it's usually separate from the general government budget, and that is sort of the system that Indonesia has adopted and is moving towards. The third primary model is one of out-of-pocket spending, where countries are basically, they don't have very strong public sector, don't have social health insurance, don't have public financing, and households end up bearing the cost of health spending. And the last two are sort of less prominent, where you have systems. For instance, in the US, up until Obamacare, primarily the health financing model was that of private health insurance. Now, with the mandate we have under Obamacare, it's becoming a little bit more complicated to classify that. And then you also have some countries that have adopted community-based insurance models. Rwanda is one example, where you have lower level pooling at the district level, or even at a lower community level, that pools resources and then purchases health services. I think the point here is that you do have these different models of how health financing or health expenditure is financed, but each model is associated with different instruments for how revenues are generated, how they are pooled, and how purchasing is done of health services across countries. But I think one key point to remember is that rarely do we see a pure form exist in a country. Many countries are increasingly hybrid models. So even if you have a model which is primarily tax financed, you do end up having some people that still pay out of pocket by choice in some cases, and in social health insurance, you may have tax financing of premium payments, or you may have tax financing of public service delivery. So the distinctions are not that clear cut. So usually many countries are sort of hybrids of these models. But they're still useful to think about in terms of primary orientation of health financing of a country. So basically, what this graph shows is, what are the average sources of health spending in low income, lower middle income, upper middle income, and high income countries. And I think the point to note in this pie chart is basically, if you look at the out-of-pocket spending share of total health spending, that is basically the sand-colored thing. It's about 44% in low-income countries. And if you notice that as countries become richer, this out-of-pocket spending share dramatically goes down to 22% in high-income countries. And if you look at the social health insurance share, you can see that it's very tiny in low-income countries, primarily because they don't have big formal sectors. And this share tends to dramatically increase on average as countries become richer. In high-income countries, it's almost, what's the number there? It's about 26% of total health spending. The other shares, the tax finance share and the private NGO tends to be remain roughly the same in similar magnitudes as you become richer, but it's really the out-of-pocket that declines and the social health insurance that tends to increase as countries become richer. Next slide, please. One key point to remember is that health financing is a means to an end. And I think it's important to contextualize health financing in terms of what the objectives of a health system are. What is it that the health financing system of a country is trying to achieve? And I think it's important now, and as most countries are moving towards universal health coverage, it's a policy objective across most developing countries. Many countries have got time-bound targets as to by when they want to achieve universal health coverage. I believe in Indonesia it's 2019, and in Vietnam it's, I think, 2020. Philippines, similar sort of dates that have been set, and UHC is really a big policy agenda now. And universal health coverage is really about ensuring that everybody has access to quality health services as needed. And the second point is very important, without facing undue financial hardship as a result. So I think this move towards UHC, or universal health coverage, it differs from previous calls for health for all in the Alma Ata, in that it not only talks about improving coverage of health services, but also about providing financial protection. And I think that's, it's really two things, so that people shouldn't have to pay a lot out of pocket when they're seeking healthcare. And so health financing is really not just about how money is spent, how much money is spent by the health sector, but also how efficiently and equitably the resources in a country are raised, how they are pooled, and how they're allocated to achieve a desired health system objective such as that of universal health coverage. And I think that's the context within which one should evaluate health financing across countries. Next slide, please. I just want to reiterate one point here that universal health coverage is about making sure everybody has access to quality health services as needed, and that they don't face financial catastrophe as a result, or don't face financial hardship as a result. Universal health coverage is not about insurance card distribution. There's sort of a misunderstanding of the concept of universal health coverage across many countries, and I just want to reiterate to make this point. In fact, I think this was late last year, the World Bank, along with WHO, has actually come up with a list of recommended indicators that countries should follow in order to assess progress towards assessing UHC. And I think there are about 13 indicators, and I've listed them, and they include things like access to family planning, measles immunization, hypertension treatment, diabetes treatment, incidence of catastrophic health expenditure, and this is, by catastrophic I mean very high as a share of income or consumption, and incidence of impoverishment resulting from high levels of health expenditure. And if you note that none of these indicators, there's nothing about insurance coverage here, so it's really about coverage with health services and about financial protection. So it's got, we don't want to measure UHC progress by looking at how many insurance cards have been distributed. At least that's not the final indicator of interest. Next slide, please. A similar point here that universal health coverage is also not social health insurance. This is also another misunderstanding that's out there with many people. Universal health coverage is a health system objective. It's not a health financing model. Social health insurance is a health financing model. And social health insurance is not a necessary precondition for obtaining universal health coverage, even though many countries do choose to go take this path of social health insurance, including Indonesia. However, let's not forget that there are many countries, or at least there are some countries, that are trying to attain universal health coverage using a tax-financed beverage model, government general revenue supply-side financing model. And Sri Lanka is a prominent example of that. You have a neighboring country of Malaysia that does not have social health insurance and is trying to, and has actually got very good health service coverage indicators and financial protection indicators using a tax finance model. Fiji is another example of a country. So, and like the point I made earlier, that many other countries are trying to attain UHC using hybrid models. So it's government general revenue demand side financing is used to augment supply side financing with or without social health insurance. And I think Indonesia is sort of in that current modality. It's got a hybrid model where some financing is coming from social health insurance, but other financing still is coming from traditional supply side of the government budget. Next slide, please. So going back to the context of health financing. So with regard to health financing for universal health coverage, I think reducing dependence on out-of-pocket payments is one key distinct goal, objective of health financing for UHC. And you want to increase the share of pool sources of financing, that's going to be key for attaining universal health coverage. Out-of-pocket payments are regressive, they're inequitable, they increase the extent and risk of impoverishment resulting from large healthcare expenditures. And most OECD countries, these are countries that one can say are closest to having attained or close to attaining UHC, they have less than 20% of total health expenditure that is out of pocket. And this is also in line with the WHO's recommendation that this should be one of the targets that one should monitor, that your out-of-pocket share should be less than 20% of total health expenditure. Indonesia is currently about 45 to 50% share is still out of pocket. The pooling share can be increased by increasing the share of health expenditure, that is general revenue finance, that means government using part of its budget, or through mandatory insurance financing. Because both of those represent forms of pooling where resources are pooled not at the time that you need care, but they're prepaid either through general taxes or through mandatory social insurance taxes. So that's, I think, key in order to attain UHC, this element of pooling and moving away from reliance on out-of-pocket expenditure. Next slide. Sorry, I can't hear you, so I have a couple more slides.
Yeah, okay, 5 minutes more, okay, yeah.
I think one of the key points is also that health financing interacts very strongly with the economy. You can't undertake health financing reforms very easily without sort of not contextualizing it as to what happens with the rest of the economy. Health financing reforms can increase labor costs if you introduce social health insurance. Also, the levels of informality and poverty in a country can constrain the choices that you may have in a country in order to implement certain types of reforms. Next slide, please. So I think one of the key points here is that government financing is key, and a key lesson for Asia, even under social health insurance models. And you have coverage for the poor across the world is non-contributory. Basically, it's the government that pays the premiums for the poor. Expansion of coverage to the non-poor informal sector is also a key challenge. It's a key challenge you're facing in Indonesia. Voluntary enrollment, even with subsidized premiums, have led to adverse selection problems, and they can threaten the sustainability of reforms. And countries such as Thailand have expanded coverage to the informal sector by government general revenue financing. So they've basically chosen to pay, even for the non-poor informal sector, not just for the poor, using the government budget, and that's been one way in which they've succeeded in getting towards closer to universal health coverage. I'll just end with a couple more slides and just giving you a flavor of some work that we're doing at the World Bank. Given the importance of government financing for universal health coverage, so in addition to making sure that the macro fiscal environment, what is the impact of the macro fiscal environment on health spending, it's also important to see whether or not health is getting the appropriate share of the government budget. And you have a very high variation across the world. You have countries such as Costa Rica. The next slide, actually. Yeah, you have countries such as Costa Rica that spend about 30% of the government budget on health, and I'm told in part because they don't have a formal military. And then you have countries like Myanmar that spend only about 1% of the government budget on health. And Indonesia is very low on this front. It only spends about 5 to 7% of the overall government budget on health. And part of this variation that we see is related to income, but I think even after controlling for income, there are big differences in the health share of the government budget across countries. And there are also, next slide please. There are also big differences across regions, and this is, like I said, this is some exploratory work that we're doing at the bank to try and understand why is it that some countries spend a greater share of their budget on health than others. And one of the facts that we see is that Latin America and Europe and Central Asian developing countries tend to spend a higher share of their budgets on health. South Asia and Middle East tend to spend a lower share, and East Asia is somewhere in the middle, and it's sort of been growing ever since. I think in the interest of time, I'll just skip some of the other slides and go to my final slide. If you go to the summary slide, the final slide. Basically, just want to reiterate some points that health financing is really a means to an end, and to be able to understand trends in health financing, we have to understand what is it that it's trying to attain. Health financing is not really just about the levels of health spending that a country is facing. It is also about how resources are raised, pooled, and allocated to attain UHC, and that can have critical implications as to how successful a country is in terms of attaining its desired objectives. And really the issue of government financing and reprioritization of health within the government budget are key for attaining UHC, and these are key challenges that Asian countries face, and I think we need to understand more what is it that is going to take to get more of the government's overall resources to health. And I think more focus is needed on health service coverage and financial protection, on measuring these, not just on how much is being spent and how many cards have been distributed in the country. It's really what are you getting from spending that and distributing the cards in terms of health service coverage and in terms of financial protection.